Hello, my name is Michael Shacklock and I'm going to show you neurodynamics or neural mobilizations for the ulnar nerve at the elbow. First of all, we have to consider reduction of force for the patient who has a lot of pain and cannot move easily. Then very slowly, as they improve, we apply force, maybe some compression and some sliding movements, and finally we apply tension and maybe with a small amount of compression. So we basically go from low force to high force in a series of rehabilitation movements to help the nerve's sensitivity, maybe viscoelastic behavior, tolerance to movement, and maybe even excursion and its extensibility as well. The first mobilization is to reduce force on the nerve, like that. This way we are shortening the nerve from both ends. Next thing we do is mobilize the nerve. That's a slider, distal, proximal, distal, proximal, keeping the elbow stable. Then we can apply more force to the nerve, distal, proximal, distal, proximal. We can apply more force by doing depression, distal, proximal. Sliding the nerve while we are applying some pressure. Then we can apply more force, and then that's distal, proximal, distal, proximal. Then we can apply even more force with abduction, which applies tension to the brachial plexus, distal, proximal, distal, proximal. Then finally, we can apply a much more force to the nerve this way with depression, distal, proximal, distal, proximal. And then we can apply tension to the nerve as if we are doing the ulnar neurodynamic test. That's a standard test we often use in diagnosis, but the treatment itself can start at a much lower progression, then slowly increase force on the nerve to the end. So we're doing extensive rehabilitation or even performance techniques for the nerve.